Hello to everyone. My name is María-Victoria Mateos. I work at the University Hospital of Salamanca in Spain, and it's my pleasure to share with you information about maintenance approaches post-autologous stem cell transplantation in myeloma. And you know that the definition of maintenance is basically therapy delivered for a prolonged period of time to at least maintain the response previously achieved. And the main objective of maintenance therapy is to eliminate the measurable residual disease or to maintain the absence of measurable residual disease or even to sustain the low levels of measurable residual disease. But definitely the aims of maintenance therapy are to reduce the risk of relapse and prolonged progression-free survival and overall survival. Treatment for patients with multiple myeloma is rapidly evolving and novel drugs are being incorporated, but we can't forget that maintenance therapy must be convenient, be safe and well tolerated long term, and if possible, not prevent the use or reduce the efficacy of other future treatments. And I think that this is important because today, after autologous stem cell transplantation, lenalidomide single agent continues being the standard of care. At a dose of 10-15 milligrams, 21 days followed by a week rest period, or len maintenance 10-15 as continuous therapy, but this is the standard of care. And it's true that under the standard of care of maintenance with lenalidomide, there are many possibilities that are coming in order to improve the maintenance approach. One of the first approaches is to utilize the proteasome inhibitors. And there are some experience with bortezomib or ixazomib single agents, and although they reported a benefit from the numerical point of view, it's true that neither ixazomib nor bortezomib had been indeed approved to be utilized as maintenance therapy. Maybe the optimal way in which we are moving forward is to add something else to lenalidomide. And we have some experience in the Forte study with carfilzomib plus lenalidomide, and we can see how the addition of carfilzomib upgrade the quality of the response. More patients converted the MRD positive into negative, and this translates into a benefit in progression-free survival. This is not the case for the proteasome inhibitor ixazomib, and the addition of ixazomib didn't report any significant benefit. But as we are entering into the immunotherapy era, new monoclonal antibodies are being also incorporated to the maintenance approach. And again, I think the optimal way is to add something to lenalidomide. And in the Griffin study, daratumumab was added to lenalidomide as maintenance. And this combination resulted in a higher efficacy in terms of a complete response rate, as well as undetectable measurable residual disease over time. We will see how this will translate also into a benefit in PFS, and definitely there is a phase 3 randomized study ongoing, the Perseus study, that will evaluate Lendex versus Len alone. And the data is not only the monoclonal antibody anti-CD38 evaluated as part of the maintenance, and the German study is also evaluating the role of isatuximab as anti-CD38 monoclonal antibody. There are many trials ongoing trying to evaluate novel combinations, but definitely the bispecific monoclonal antibodies like teclistamab or elranatamab are going to be also evaluated as part of the maintenance therapy. And another important approach in terms of maintenance is maybe to define what is the optimal duration of therapy. In principle, today we are giving maintenance until progressive disease, but we realize that myeloma has to be converted into a curable disease. And maybe as we are increasing the intensity of the maintenance therapy by the addition of monoclonal antibodies, maybe we have to plan not duration, no durability of the maintenance until progressive disease, but maybe fixed duration, and the quality of the response, especially the minimal residual disease negativity achievement, can be an optimal driver in order to plan maintenance of fixed duration. This is mainly applicable to patients with standard risk, because maybe patients with high-risk features would benefit from continuous therapy until progressive disease. And these are my conclusions. Definitely maintenance seems to benefit to patients after transplant, and developing early endpoints as surrogate markers for long-term outcomes and overall survival is critically important. Otherwise, trials may continue for more than 15 years before confirming the superiority in overall survival. Thank you very much.